Hello everyone. We have a 36-year-old man recently diagnosed with Hodgkin lymphoma. And he come to you due to fatigue and generalized edema. The lab results show that the creatinine is normal, but albumin is reduced. Globulin is increased, and this is again in the normal range. The main thing is albumin reduced and globulin is increased. Urine analysis show 4 plus proteinuria, massive proteinuria with no hematuria. That means there is isolated proteinuria is there. Vitals are normal. Which of the following glomerular disease is most likely to be present in this patient? So in nutshell, we are getting a patient of Hodgkin lymphoma coming with nephrotic syndrome. While you can say massive proteinuria there, no hematuria, so goes more in favor of nephrotic syndrome. But what the most likely cause? What our problem is all minimal change. Well, we all know very well idiopathic variety of minimal change is common in children. But here we are getting 36-year man with lymphoma, Hodgkin lymphoma. So a variety of glomerular disease may be seen in setting of various malignancies. Okay, but now patient has nephrotic syndrome indicated by high degree of proteinuria, as I told you, hypoalbuminemia and edema. Urine analysis show 4 plus proteinuria and generalized edema. That is given in the patient history also. Now, he has been recently been diagnosed by Hodgkin lymphoma. Now, minimal chain disease is the most common form of nephrotic syndrome in patients with Hodgkin lymphoma is very, very important point. Don't forget. So, Hodgkin lymphoma, the golden line to remember. Hodgkin lymphoma is, and if you are patient having nephrotic syndrome, think about minimal chain disease. Is a golden line to remember. Nephrotic syndrome usually resolved with successful treatment of lymphoma. Overall, membranous glomerulopathy is the most common form of nephrotic syndrome associated with malignancy. And usual malignancy are solid cancer, lung, colon, prostates. So if the question was the patient has a colon cancer, then the answer would have been membranous. Okay, not the Hodgkin. But here we have a MCD with Hodgkin lymphoma. I told you the golden line to remember is that Hodgkin lymphoma is minimal chain glomerulonephritis. So this awareness of the disease association may help the screening and detection of underlying condition in patient with nephrotic syndrome. Now let's look into other option. Amyloidosis. This can lead to nephrotic syndrome, but this is especially seen in multiple myeloma, not in Hodgkin lymphoma. Weight gain and lower extremity edema may occur at a slow pace and may initially go unnoticed by patient or physician. This is a very slow process. Okay. Now, I have a question for you. Stop the video, write down the answer. We just read it that in multiple myeloma, patient can develop nephrotic syndrome and patient even can develop chronic renal failure can occur in multiple myeloma. But my question is, which factor which contribute to chronic renal failure in a case of multiple myeloma? Stop the video, write down the answer. Which factor contribute? Well, answer is deposition of immunoglobulin in light chain in the renal tubules, hypercalcemia causing microcalculi formation in renal tubules, amyloidosis and recurrent UTI causing chronic pyelonephritis. So they are the factors which contribute to chronic renal failure in case of multiple myeloma. Well, I like to talk about this line also. Let's say this is the nephron. And proteins are filtered and they are coming into the tubule. And of course, microcalculi are there which also contribute. Finally, these unite, these protein, they unite and they block the nephron. So they are blocking the nephron. So this is known as lower nephron nephrosis. Okay. So of course, as I told you, the other feature which contribute to chronic renal failure. Let's look into other option. Cystic glomerulonephritis does not have a, now this patient those who have cystic glomerulonephritis, they come with the acute renal failure. Okay, everyone, they develop very fast hematuria and hypertension, but in our case no hematuria, vitals are within normal limits, so this ruled out. In addition, even when we saw the report, the lab report, that there is nothing wrong with the kidney function test. In addition, cystic glomerulonephritis is usually associated with autoimmune disorder, not with malignancy like SLE, Sjogren syndrome, not with malignancies. Focal and segmental glomerular sclerosis, FSGS, is associated with HIV, heroin, drug abuse, obesity, and vesico-ureteric reflux. This is in children. It's not a classical associated with any malignancy. Membranoproliferative is associated with hepatitis B and C. Chronic bacterial infection like endocarditis, autoimmune like SLE is uncommonly associated with leukemia, CLL, or lymphoma. It is typically not seen in Hodgkin lymphoma. But now I have a question for you. Stop the video, write down the answer. What are the pathology of various type of glomerulopathies? Write down the answer. This is very essential to know about the pathophysiology and treatment. All depend on what type of pathology is there. Stop the video, write down the answer. Pathology of various type of glomerulonephritis. Well, so before we discuss pathology, let's learn the normal histology. Unless you know the normal histology, you will not understand. This is the epithelial cell. Yeah, this is the epithelial cell. These are the foot process. Foot processes are also known as podocyte. This is the glomerular basement membrane. This is the capillary endothelium. Capillary. This is a lumen. L for lumen of the capillary. You can see this wall of the capillary which is facing toward the basement membrane has pores. These are the pores. This is normal histology. So now what happened in minimal change disease? This loss of foot process. You can see these foot processes were like this. Now they have become like this. So in minimal change, loss of podocyte or PDP, and podocyte, or loss of foot process is what happened in minimal change. In membranous like this, there is subepithelial deposition of antigen antibody. Subepithelial. Deposition of antigen antibody. This is known as spike and dome pattern. Now, what happened in FSGS? Focal and segmental glomerulosclerosis. There also loss of food process occur, the way it happened in minimal change. Many people say that FSGS is a continuation of minimal change disease. Loss of food process, but there is difference. This happened in minimal change, but here, now what happened? This get detached. That means the epithelial cell get detached from the glomerular basement membrane. In addition to that, this is the mesangial cells. Mesangial cell is the supporting cell. And this is the mesangial matrix, that is supporting soft connective tissue. Antigen antibody deposition occurs in the mesangial matrix. Remember, in minimal change, there was no deposition of antigen antibody. Finally, we have a membranoproliferative glomerulonephritis. This is a enlarged view of glomerular basement membrane, enlarged view of GBM. Mesangial cell proliferates and enter the basement membrane. It make a tram tract appearance. Tram tract appearances there. So this is the basic pathology of so-called 4 important type of primary glomerular disease. Now a quick recap of the last minute revision point. Primary renal disease causing nephrotic syndrome. Focal and segmental glomerulonephritis seen in obesity, HIV, heroin use. Membranous adenocarcinoma, breast, lung, NSAID, hepatitis B, SLE. Membranoproliferative B and C and lipodystrophy. Minimal change NSAID lymphoma or HIV also. And IgA nephropathy, upper respiratory tract infection. Golden line to remember, membranous nephropathy is the most common form of nephrotic syndrome associated with cancer. Minimal change usually seen in patients with Hodgkin lymphoma. Thank you very much.